We have a special offer for our Munch Bunch listeners. To book a virtual consult with Megan, she's offering a discount of $25 off. Just email her, Megan, at nwmyofunctionaltherapy.com or through her website, www.orofacial-myology.com. To book a virtual consult with Kimmy for the $25 off, email her mouthmusclememory@outlook.com or through the website www.mouthmusclememory.com. Now on to the episode.
This is the Munch Bunch Myo podcast. This is Kimi Nishimoto with my co-host Megan Van Noy. And today we have an awesome guest, Dr. Larry Kotlow, the author of SOS for TOTS. You probably have heard of it.
Yeah. There it is.
There it is. So Dr. Kotlow is a really special dentist who is kind of the OG pioneer for tongue tie releases, especially for babies. He has helped many, many babies over the years. And today he's going to talk to us about the tongue, how it helps to build the face, the palate, and answer the question, is the tongue a muscle or an organ?
Yes. And beyond that, he has a whole tongue tie grading system named after him. So, he's kind of a big deal. And so, so we're planning to pick his brain kind of endlessly here. But yes, Dr. Kotlow, will you just briefly kind of tell us about you, a little bit of your history, what got you even into the tongue tie space, and then we'll dive in.
Basically, I've been in practice for quite a while, 48 years. We learned nothing about the tongue other than it was for chewing and taste in dental school. It was never discussed in our residency program. And really, when I came back to my hometown and set up my practice, and I saw tongue ties that were severe, and these are just older kids, no one would do them without putting them into the hospital. So I took out one of my textbooks and said, okay, I got to learn to do this in the office. And more and more and more I did it. But as I work with the tongue, I realized that the tongue is far more than just a muscle. Just like the heart is a muscle, but it pumps blood throughout your body and provides nourishment for your brain and all your muscles and everything else. And if you really look at the tongue is connected from the top of your head to your toes by body fascia. So that if you're tied as an adult, you end up with TMJ problems, shoulder problems, back problems. And that's why you can't just look at it as an individual treating the problem. We have a team. And the team involves myofunctional therapists, speech therapy, eating specialists, pediatric dentists, people who kind of know what the tongue does. So we can break it into different categories. And you mentioned the palate. And how it affects that. So in utero, that piece of skin under our tongue is supposed to really disappear. It's called apoptosis. And it's not inflammatory, it just kind of melts away. But if it doesn't, then if it becomes restrictive, it can start to affect almost all of your body systems. So we can talk about them individually, but in general, think about it. If your tongue is blocking your airway, it's going to reduce oxygen flow, into your lungs. If you reduce oxygen flow into your lungs, you're reducing oxygen flow throughout your body. Now, our brain, an infant's brain, is developing at a rate of 1% per day for the first 90 days. So within that first 90 days, that tongue is restricted enough to block the airway. Some of these children are the children who have ADD and ADHD. And here's one of our problems, and that is when you've got a child who you think is hyperactive or has some problems, and you go to your physician, they either want to use drugs, but they never look at the tongue as part of their differential diagnosis. So you as a parent need to understand that when you look in the mouth and take a look at your child's tongue, if that piece of skin underneath seems to be causing it to be restrictive, then it goes from what we call normal function to restrictive function.
Mm-hmm.
And down the line, if you took 100 kids who were, say, 10 years old and put them in a room, and they were all bouncing all over the place and hyperactive. And you put neurologists in there, they classify them as ADD or ADHD. But not one of them would look in the mouth to determine maybe it's an airway problem. So when I see a 2, 3, any age child who walks into my office, whether they're new patients or existing patients, I'm not just looking at teeth. I'm looking at the patient. And if they come in with big circles under their eyes, that's a hint that they're not getting a good night's sleep. If they're not getting a good night's sleep, that means the tongue is not functioning properly and the airway is being blocked. And then there's a question, is it tonsils, adenoids, or the tongue? Well, if the tongue is blocking the airway, it's going to cause irritation to the tonsils and they're going to become enlarged. So which comes first, the enlarged tonsils or the tongue? So we're back to the original question, and that is, why isn't the tongue being used as a differential diagnosis when these physicians are looking into the mouth? And it's the parents who have to take the lead. So any parent out there who listens, go to my website. It's Kids Teeth, KIDDSTEETH.com. And if you go to forms, I have a form on there that says airway problems, sleep apnea. There's 2 forms. One is for infants, newborns, and one is for sleep apnea. Now, it's KIDDS, 2 Ds, KIDDSTEETH. And if you start to look, there's over 30 symptoms of sleep apnea from a 2-year-old or 18-month-old all the way up to an adult. Now, you've been flying. What time is it where you are now? You've been around the world here. So
it's midnight.
Okay, in a couple of days. You know how you feel when you don't get a good night's rest? Where you take a child at any age or an adult who are not sleeping through the night regularly, not just once or twice a month or something. Okay, you know how miserable you feel. Well, these kids feel miserable all the time. So that's another thing we need to look at from the airway standpoint is, are we preventing good oxygenation to that infant's brain? Now, if we do that and we look carefully, we can intercept or prevent problems. If you or I have that problem, now we have to go in there and treat the problem. What's the cause of it? So prevention versus treatment. Same thing with babies who come in with reflux. Okay, you as a parent have a newborn and they're throwing up all day long. You take them to the doctor and they put them on drugs, which if you read from the FDA, they're not recommended for children.
No, that's what I think
because
is crazy. Yeah.
They don't have reflux.
Right.
What they have is what we call air-induced reflux. Okay, so if you take a look at your finger and look at your fingernail, that's your nipple, the mother's breast. Between the 2 knuckles is your areola. So if the baby's hanging around here, what they end up doing is sucking air, their belly gets distended, they arch their back, they cry all night. And that's not a way to start. If you read my book, the opening chapter says, the first line, for 9 long months, you've been waiting for your baby and you've been told how wonderful it's going to be. And in the first 5 minutes, it's like on a scale of 1 to 10, I'm toe curling 21 when the baby bites down on your nipple and hurts.
Yes, okay. It is from personal experience. Yes, I can attest to that big time.
And the doctor says, well,
put him back in.
Right. Well, the doctor says, you're a new mother. You're just not used to it. Or your grandmother says, it's supposed to be painful. Well, yeah, breastfeeding should be fun and pleasurable and calming. So now as we progress down the line and we look at what's going on, we find that these babies are the babies because the tongue also is what we call the architect of the mouth.
I love that.
What that means is right now for both of you, okay, I know the answer already, but both of you relax. Okay, Megan, what is your tongue touching right now?
Well, right now it's the roof of the mouth.
Your top front teeth, right?
Mine's the roof of the mouth, but for years,
yes,
definitely my top front teeth. I was the colicky baby who needed an orthodontic expander, who turned into the adult with all the problems you already just said.
Okay, now, if I look at your mouth, Kim, Where's your tongue touching?
The
No,
roof.
not now. When you push it up there at rest.
That's where she lives at rest. Mm-hmm.
Where did you sure?
Mm-hmm.
Okay, if you just totally relax, that's where it's going.
Mm-hmm.
Okay.
Yeah. Now ask us
So-
this question 5 years ago.
Yeah. But in the past, it was
5
Yes.
years ago, my lingual retainer all day long. And then if not, sometimes in my little open bite.
Okay.
my tongue used to live here because I was a mouth breather. So it'd just be.
So again, actually, what you just showed me, I had a baby yesterday, newborn. It was about 3 weeks old, and that's how the baby came in. And the reason they came in was because the tongue kept sticking out of their mouth, and the doctors were worried about all sorts of problems. The reality was, once we released the tongue, went back in the mouth. But let's get back to the architect. So the tongue in utero rests in the roof of the mouth, and it allows the upper jaw to expand outward. So our upper jaw should be more of a horseshoe than a tent. But if that tongue has been tethered in utero and it's not taken care of, the tongue doesn't work, and you get a high arch palate. This is why some of these babies come in with high arch palates. Okay, so now we get into palatal expansion when you're older, but then we're going to go back to the baby again. So if the upper arch is constricted, what does that mean? It means the lower arch is going to be constricted because the lower arch grows within the upper arch under normal conditions. So now we're developing skeletal problems. So we talked about, a breathing problem, oxygenation. We talked about respiratory problems with our lungs. We're talking about bone and neural growth and development. Now, another thing is when that baby is born, not only should the baby be able to latch, but that tongue should be starting to stimulate the area in front of the anterior papilla, kind of jumpstart the baby's nervous system. So now we're talking skeletal, neuromuscular, nervous, brain development, oxygenation. So let's go back to the question you asked me, is the tongue a muscle or is it an organ? Well, it affects all of the body systems. Now, as a mother, you're all psyched for this baby. Now we have another problem here, and that is mentally, you're not prepared to be depressed. And one of the functions of nursing is holding that baby close to you and bonding. So if that baby is keeping you up all night screaming and you're walking the floors and you're not getting any sleep and neither is the baby, you're starting to develop a non-bonding, almost adversarial relationship.
That is so interesting.
And then,
But yeah, I could see that actually, because most of the people that I know that have had bad postpartum, they've had difficult babies too.
so what's the answer? So you go to your OBGYN or your primary doctor, and what are they going to do if you're in depression? They're going to put you on a drug to try to help you. Now that has two problems. One is it ain't going to work. Number two, now you may have to stop even thinking of breastfeeding if that drug is going to pass through your milk to the baby. So now you get more depressed. Now, if you reach a high enough depression rate and you increase certain chemicals in your body, it's going to reduce your milk supply, which is going to further reduce your mental status. So now we're treating endocrine because when that baby is born, the brain is told to produce milk. When the baby gets near it, it's told to, have that milk come out. Now, if the baby's not latching, your milk supply is going to drop. Even if you pump, eventually it's going to start to go down. And who wants to pump 24/7? So that's the question again. It affects almost every single body system that you have, either directly or indirectly. So we need to look at the tongue as part of differential diagnosis for almost every part of the body.
I agree. And it's so refreshing to hear like a dentist say that, because sometimes I feel like as myofunctional therapists or airway dentists, like we're in our own camp and then everyone else is in a different camp. So I love to hear you say that, because working with patients, we've seen time and time and time again how working on tongue function, breathing, and chewing gives better health over the whole body. So I love to hear you say that. I'm so excited right now.
Yeah, every symptom. And what's interesting, so Dr. Kotlow, we've talked about my story enough, so I'm not going to spend all of our time talking about it. But I've been practicing myofunctional therapy for almost 7 years. Was a patient, had my tongue tie released, but then I had my daughter 17 months ago. And our journey was really, really hard because she was lip, tongue, cheek tied. We had them released at 9 days old. We worked up, down, through the moon. Like we were at Melissa Cole's office here in Portland at, weekly, if not twice a week, trying to get my supply to come in. And it was such a challenge that I had heard about and had like empathy towards, but until I really experienced it as a mom and what that looked like, it was rough. And it was really eye-opening from a different direction.
Well, it's very frustrating because what you just said to me, I hear 10 or 12 times a day. I treat anywhere from 10 to 17 patients a day for this.
Yeah.
Wow.
Okay. And it's the same story because when you listen to people lecture, they have this distorted view of themselves, I think. I hear all the time, it takes a village to build, et cetera, et cetera. But the village has to be educated, number one. Number two, then I hear you need to stay in your own lane. Well, I drive a Tesla and the guy in front of me is doing 20 miles an hour. I'm going to move. So if the general community is behind me, I'm not going to stay in my own lane.
Beep, beep.
Not even beep, beep. I'm just going to say, excuse me, and take off. But you need to understand that within all of our specialties, there's a big void in knowledge. And, maybe 20% of the myofunctional therapists and lactation people are really understanding all of this. Because when I get kids who come in and they've had 3 months of therapy and they're now 6 months old, they've missed that 90 days, that 2-year-old, you're from 90 to 2 years old. So, I've come up with categorizing tongue ties. Very simple. I don't use all this fancy stuff, millimeter here and a millimeter here. You have to do it by 3 things: function, appearance, and where the attachment really is. Okay.
Love that.
So if it's at the base of the tongue, it's class 1, and the lactation people reverse it. And I don't understand that, because if you're dealing with cancer, stage 4 is the most serious. So the tongue to the tip is going to be the most serious.
Right.
And that's the category. That's why it should be class 1, 2, 3, and 4. The word posterior tie should be eliminated from our vocabulary because the medical community thinks it's minor. Parents come in, oh, it's just a posterior tie. Well, I equate when someone comes in and said, I had it snipped with a pair of scissors, telling me their baby had a circumcision, but they only did half. Okay.
Yeah. Oh, yeah.
You've got to release the tongue, whether it's at the tip, midline, or the base, down to the base of the tongue. And then you have to do the proper aftercare. So you've got to know that when you look at the tongue, and I don't know, are you aware of the new instruments that I've developed?
No, tell us about it.
Okay, so I'm working with a company called Armor Dental. It's AMOR-DENTAL. And we've developed 3 new instruments, actually 4. One of them is called, you use your groove director. Okay, well, that's a metal instrument, which is cold, hard steel. And it's very unergonomic. So we developed instruments that have handles like this. This is another instrument. Okay, this is called Comfort Soft. And what this does, it goes in right in your cheek. Okay, into the older kids' mouth, so you can see what's going around their mouth. But we've also developed one that's got a groove in it. That allows you to take it under the tongue and stretch the frenum. So you can see, if you go to my website again, There's a whole area on this instrument. But I've developed it with them. It took us a year. And it's meant for not just me to do surgery, but for all of the people. And I don't really like to call it the breastfeeding team. I like to call it the tongue tie team, if you want to call it. But everybody who's working in the mouth, it allows you better visualization of that frenum, not looking in the mother's lap. You get behind the baby. And that's the other problem. The physicians say, oh, there's nothing wrong there.
Mm-hmm.
And then there's the misconception that if the tongue comes out of the mouth, there's no problem. Because the medical community, dentists, and many people don't understand that in order for the mom, for you guys to get milk out, it's not the tongue coming forward, it's creating negative pressure in a vacuum. So that by creating that tongue in the back going up and down, it creates that negative pressure and therefore not compression. So when someone comes in and says, oh, the doctor said it's a posterior tie, nothing to worry about, the baby's gaining weight. So you have to ask the right questions. So one of the questions is, do you have an oversupply? Okay, when the baby looks at you, does your milk just squirt out? That's why the baby's gaining weight, because you're waterboarding him. It doesn't have to really latch on. So there are so many different things you need to look at when you're evaluating the tongue, that if it's not evaluated properly, and we can discuss how to evaluate your child, maybe at another discussion if you want, because we can talk about that for quite a few minutes too. But I think to answer, going back to your original question, I hopefully have answered it. The tongue is more than just a muscle. It's an organ which affects your entire body.
Yeah.
And then if the old school of orthodontics continues to have their way, where they take out bicuspids and they push everything back, all they're doing is closing the airway. Mm-hmm. And again, the upper jaw has to be brought forward to open the airway. Mm-hmm. And I think you were talking to another doctor before, where you talked about that airway and the upper jaw. Mm-hmm. So everything has to be brought forward, and that's going to open up the airway.
Yeah, mm-hmm. And actually, Kimmy was a classic premolar extraction case, and she's been kind of on that journey to eventually, hopefully, open that space back up, because that's exactly what happened to her.
Mm-hmm. Yep, all the negative side effects, TMJ, small airway, sleep apnea, all the things.
You know, people come into me, and after I look at their kid, they say, "Am I tongue-tied?" And I ask them the same kind of questions. You know, they don't need to go on a CPAP machine. They may need to lose 40 pounds sometimes, but, you know, they need to have the tongue looked at. I was a member of a study club before COVID hit and snoring and tongue and the tongue. Okay, there were 20 doctors there. And after 2 hours listening to them about how dentists can't make a diagnosis and how dentists can't treat it without a prescription, what I said was, how many of you look at the tongue for tongue tie? And not one answered the question. Mm-hmm. So I said, you're putting a patient into a device to try to correct a problem that what you need to do is release the tongue. Now, I'm not going to say that's going to happen all the time, but it should be part of the differential diagnosis for almost everything when you're dealing with that area above the head and neck that's not, you know, a tumor or something someplace. Mm-hmm. All these newborns and toddlers and infants who come in and they're told nothing's wrong, you're a new mother, you're over concerned. Mothers got to go by their gut feeling. If they're told there's nothing wrong and they know there's something wrong, they need to find somebody who can make the assessment, diagnosis, and treatment. And, you know, now we're back to the lactation people and you guys who are myofunctional therapists. And that is, the word assessment and the word diagnosis are the same. And we get hung up in the terminology. And then again, there are people out there, they, oh no, I can only make the diagnosis. Okay, I may be only one who can treat it surgically, but you should be able to make that assessment and refer out, whether you're a hospital base or your home base, because, as a nurse, if I come in and I got black and blue and I'm going to the bathroom a lot at night, I'm drinking a lot at night, and I'm tired, you're going to say, boy, you have a lot of symptoms which indicate you might have diabetes. To your physician. And the same thing here. Your tongue appears to be causing some of your problems. It may be we call ankylosis or tongue-tied. And I want to refer you to this person for an evaluation. And, in your evaluation, you say, it appears the area is restricted. And you work as a team so that, you're looking at it and correctly. And we go back to the area again where the assessment is done, not trying to say, you're going to fix it in 3 months. If we go back to my classification, see, the classifications that I use make it simple for us to know who should see the baby.
Right.
So I have a flow sheet, and some people don't like it, but my feeling is this: the baby's born in the hospital or at home, you have a midwife, and obviously the baby is put onto the mom's chest, but within that first 12, 24 hours, someone should take their finger and swipe it across the floor of the mouth and get a feel if there's something wrong. Now, when you look, if it goes into my class 3 or class 4 category, I don't care what your profession is. You're not going to stretch the tongue because it's not going to happen. And don't waste time trying to do all sorts of positioning and gimmicks. Get the tongue released and then work with the mother. So if it's a class 3 or a class 4, it's real tight. Once you do your assessment, they should go right to the person who's going to release it and then come right back to you. And then they go into body work. Now, if it's a class,
I love that. When
it's a class, 1 or 2, okay, maybe there's a workaround that you can do. Maybe spend a few days trying to work around it, because we all have an attachment. So if it's a minor attachment, but if after 3 or 4 days, 5 days, nothing's going on and that mother's in pain, it's an easy fix. It's not very invasive. Now, let's talk about, well, maybe we should save it to later. Talk about assessment and then how to do the surgery and what the best way to do the surgery. Maybe another time we should do that, because I think that's important.
Yeah. I think Kimmy had a question.
Yes. What is the percentage or of the genetic factor for the tongue tie? Because anecdotally, a lot of times if I have kids that are tongue tied and I look at one or both of the parents, they always have some form of restriction. Are you aware of like an actual number, or what is your opinion on the genetic dominance of that?
Okay, so you're going to get opinions all over the board. You're going to read the articles and they're going to say 5 to 10%. Then they're going to tell you it's a fad. Let's go back to the 1700s. Our lifespan wasn't very long. Babies who were tongue-tied and couldn't nurse died. Or you had a midwife who took their fingernail and zapped it. Okay, and we didn't have any knowledge about infection control, cleanliness, washing our hands. They could die from an infection. As we progressed further down the line, we had wet nurses and we had mothers who didn't want to nurse because they were bound up in all these fancy outfits they used to wear in the 17 and 1800s. Then as time progressed, and we're going to jump into the 60s, what happened in the 60s? Well, 2 things happened in the 60s, 50s and 60s. In the 50s, we had the milk manufacturers, formula telling us we can do everything. Everything is great. There's no problem. We can make the perfect milk for your baby. Nobody had any indication that in the morning and in the evening and the afternoon, mother's milk is not the same. Okay. The formulation of your milk during the day, there's more fat, and I think it's in the morning than there is in the evening. So your milk, if you're pumping, you should pump, if you're going to pump in the morning, you should make all the milk that you pump in the morning for morning bottle feeding. If you pump in the evening, that should be for your evening, because the milk is different. And science is discovering your milk supply is going to change during the day and during your mood. So that's number one. Number two, during the Korean War and World War II, women were not encouraged to breastfeed because they had to actually go into the workforce. Now, what happened in the 60s? We had the hippies. They wanted natural childbirth. They wanted no drugs. They wanted to breastfeed. When my kids were born in the early 70s, I got all my formula free because of my residency program. My daughter never saw breast milk, neither did any of my kids. That wasn't the way to do it. 20% of women in this country, so 20% of about 4 million babies were being breastfed. Okay, now let's jump a little bit further into the future. If 20% of babies were being breastfed in the 70s, as we go into the 80s and 90s, and now we have close to 85 or higher percentage of women wanting to breastfeed. It's no longer a mechanism feeding your baby for poor people. We know over-the-counter formula may be good, but it's not as good as mother's milk. We know that breastfeeding is not just for milk. It's for facial growth and development and all the things we talked about. The immunity the mother passes to the baby, the benefits to the mother. And I could go on and on that what medicine has shown, breastfeeding is not only good for nursing purposes, but for the mother's health, the baby's health. Okay, so now we're into the 90s and the 2000s, and we've got 85% of women nursing. So now we've got 5 million babies being born. So you got almost 4 million babies being nursed. Therefore, babies are living longer. There are more babies nursing. And therefore, the problems are not more today than they were then, but there are more people nursing. So the problems become more well known.
And also, you don't have that sensation of nipple pain or whatnot from nursing if there's a tongue tie, if they're bottle feeding. They just think it's a flow issue. So and that makes it tough too.
The thing is, the only difference between bottle feeding and breastfeeding is it doesn't hurt the mother. All of the other symptoms, such as reflux and airway problems, they're all going to happen on the bottle. And, when we get babies coming in where they're doing both, the bottle has a nipple that looks like that. Okay. That's not the way your nipples look like.
Right.
So once we fix it, the baby gets right down on the plastic. So we have to change the bottles they're using. So it's not you come to my practice and I cut your kid's tongue and send you home. You watch a movie for about 15 minutes, which goes over most of what we've talked about to give you a basis of why we're doing it, not just for making nursing. Mothers come in and say, well, I want to put my baby through it. If I have to suffer, that's okay. Nursing is a bonding moment which should be pleasurable. It should be happiness. It shouldn't be stressful and a struggle. Now, putting all that together, did you ever think you're going to hear this conversation coming out of a dentist's mouth? If someone asked me 50 years ago when I graduated dental school what I was going to be doing if I wasn't retired, would I be lecturing on, would I be speaking on, if they told me it was talking about breastfeeding and all that kind of stuff, I would have said, you're out of your mind. And there are some dentists who still think it's not within our scope. But Aetna Insurance was a funny case because I had a parent who came in who worked for Aetna, and they said they wouldn't pay to have me do the surgery, but if they wanted to go to the hospital and have ENT, they would do it. Obviously, we did it. But on their website, they do talk about the necessity of breastfeeding, and they show the references. I think 3 of the references were me.
No way.
Okay, my article. So the father was going to go back. I don't know what happened, and say, look, how can you deny me letting him do the surgery when you're using him to justify a surgery?
That is awesome.
So the guy who wrote it, we can't see him? How does that work?
So I think within, I don't know how long we've spoken, but in the time frame, we've covered why the tongue is a muscle, but it's really an organ.
Yeah,
Just
and
like
even
that.
so much more, even so much more. Yeah, it's the history piece is really, really interesting. I think we learned, a handful of a lot of it in our airway myofunctional breastfeeding courses, but I don't think patients get to hear it like this. And that's what I think is, or the general population.
if they
And
go to
so
my
it's
website, it's
yeah,
all outlined there and talked about, and all the
perfect.
forms are there.
Yeah, we're gonna
And
link the
parents
website. Hmm.
can make their own assessment on their own, and then
Mhm.
search somebody out who can take care of them. But don't,
Yeah.
go by your gut feeling. Don't let any professional tell you it's all in your mind when you know your
Mhm.
baby and you are suffering.
Hmm.
So, Dr. Kotlow, I have a question for you. Did you get a lot of hate being such a champion for breastfeeding? Or,
Well, I
yeah,
don't
because
think,
some people get very defensive about breastfeeding versus bottle feeding, and sometimes it's not their fault. Like Megan, it was not her fault because her body it just didn't
oh no,
work.
I have a video that you see, and it says, you know, for those parents who choose to bottle feed, that's an option you have, but you still are going to have the same problems. I've never criticized someone for using the bottle. When a baby comes in and they're on the bottle, I'll ask the mother, is it your choice to bottle feed, or is there a reason for it? And if they start giving me all the reasons, they're in pain and their first baby was terrible, then I'll start to talk about what occurred and why it's beneficial. But I have mothers who've had breast reduction surgery. I've had mothers who are taking medication or drug therapy for one reason or another. So no, the first thing I do to a mother when she comes in and I start this is say, look, I want to take all the guilt off your shoulders. The fact that your baby can't nurse has nothing to do with you. It is not your fault. Okay. Nothing at all has to do with you. And I'm going to help you. And if you're crying right now, that's fine. But when you cry, when you leave it, hopefully it'll be tears of joy because we've taken that weight off your shoulders. So no, I never received any hate. I've never discussed that negatively. I don't put it. I mean, I've got gay parents who come in, men, lesbians, homosexuals who either choose not to or obviously can't. So, I have a large number of women who are married, and I've got a few men. But they can still have the bottle problem and the same kind of symptoms. So, no, I would never, ever chastise a parent for choosing to bottle feed over breastfeeding. I would give them reasons if they could. And then I've got mothers who, they come in with inverted nipples or very short nipples, and, they've tried with a nipple shield and they just can't do it. And that's where, the lactation person hopefully comes in and has them pumping and trying to work with them to get the nipples out. But there's a certain point where some women give up because it's too stressful for them. But again, no, that I would never do. I've never received any hate. I get pediatricians who say we do it for the money. And when I send them to body workers, they say it quacks and they don't want to use any of the other, auxiliaries. But, I don't
professional
care.
hate.
It doesn't bother me. It's, I always tell anybody who's criticized, show me the peer-reviewed document that says what I'm doing is harmful. And I want to read it because anybody can write an article. And, some people, when they evaluate things, just pass them through. They don't know what they're doing.
Yeah, I think that's
never
so
been a
true.
question.
Yeah, write an article versus what's peer reviewed, what's really research based. And I think that's where a lot of fear-based things can come from, or a lot of look, here's proof. It's I could have written that if I wanted to and stamped it as new evidence. Joe Schmo could do that, and if it catches fire, but what's really true, what's research-based, what's validated. And I think that's sometimes really hard, especially with social media, especially with the internet. It's hard for people to wade through too.
I think that the only place that really gives us a problem is the medical community. And then there's some dentists who for the wrong reasons, but media is always on the side of the mother who wants to breastfeed. okay, or the mommy blogs are on the air, are there. So when you get on the internet, and unfortunately, that's how a lot of patients get to us. When you're on the internet, that's where parents get to us, unfortunately, or friends. Or I mean, I have so many people who come in. My sister was in last week and told me what a wonderful job you guys did and how she's nursing, and I'm struggling. So I came to see you.
Yeah, which is amazing. Yeah, it can be a blessing or a curse of, finding the right people, the right group, the word of mouth. Like it's amazing. And I ran into that. Kimmy knows I had like 3 girlfriends who also had babies all within the same time as me, all varying degrees. Isabel was a tongue tied to the tip, little heart-shaped baby. And I tried to schedule her for frenectomy before she was even born. So for me, but some of my other friends who had varying issues, and we've kind of briefly brought it up, and they're like, well, I asked my doctor, and I was like, well, you guys remember like what we talked about. But everybody kind of has to arrive at their own conclusions when they're ready. And when they're ready, we just support them within that. So
interestingly, because a lot of times we talk about like mother's pain, or like if they're not gaining weight and things like that. But my sister, I have 6 sisters. There's 7 girls in my family. We're all biologically related. We all have different levels of tongue tie. And it's really interesting to like talk to my mom and kind of get each one of our symptoms throughout our lives, which we need to have old Pam on the podcast so we can do that. But my sister, who's younger than me, I checked her out. She's got I'd call it like a grade 3 range of motion when she lifts it. And she doesn't really have any symptoms as an adult. So I'm like, you do you. But when she was a baby, she had really bad reflux, and so much so that her vocal cords were damaged. And when she would talk, when she was up to 3 to 4 years old, she was very raspy from the reflux when she was a baby. And my parents had to sleep with her upright or she would stop breathing. So for months of her life, she just had to be held, and they had to stay awake in shifts because she would just stop breathing at night. Now we know that she was tongue tied. So she's pregnant right now. And I warned her, I'm like, you and your husband are tongue tied. So we're going to be prepared because your baby very, very likely is going to be tied.
Well, it's funny you talk about the raspy voice. Some of these movie stars that have that kind of raspy voice. I wonder how many of them were tongue tied or are tongue tied. Now that I never thought of it in those terms of the raspy voice being related to a tongue tie. And I would guess nobody else did because they never looked at it. I mean, now that's their way of speaking. If you go and correct it, they may have a problem. But every day you listen to people with their problems, and you learn more and more about going back to the original question that the tongue is more than a muscle and how it can affect so much of your body. But we need to go back to, don't stay in your own lane. Be confident in what you do, refer correctly, treat correctly, and, build a village of support that, you can depend upon at the right time. Not some of these people who say every baby needs to see a myofunctional therapist first, and every baby needs to do this, and every person. I mean, we need to work as a team. When I have patients who drive 10 hours or 8 hours, I'm not going to turn them around and send them home. I'm going to tell them what they need to do. Okay. And they get to me through third parties. Right. If they got to me through the myofunctional therapist, or they got to me through a chiropractor or a body worker or lactation person. I mean, I saw a kid today, 17 years old. Okay. And no one ever looked in his mouth. And, he was having some airway problems now. And his tongue was right to the tip. And what's interesting? If you see a kid before they you have surgery done for them, take a photograph of them standing up like this, and you'll notice their head's tipping forward.
Oh yeah.
5 minutes after surgery, they're straight like this. I don't do adults, but when I do training sometimes with the lasers I use, A mother will come in with 2 or 3 kids and say, am I tongue tied? And I'll say, yes. Well, I need, once in a while, I'll bring a person in on a weekend when I'm doing a training to do it live.
Mm-hmm.
And the mothers are the ones I bring in because I'm confident they're going to behave themselves, you know. Anyway, I had one who came in and said, oh my God, can't believe this. My whole neck dropped because that Hoya bone just drops down. Okay. When I'm working on infants and newborns, the way my assistant holds the baby, when I release the tongue, she says, wow, everything here just relaxes. So again, there are so many symptoms we can see to her. We're tight, and it's related neuromuscular, and all of the stretching of the fascia is not going to help if we have an attachment. I talk about putting a rubber band around your waist and one on your arm and attaching them. Okay, and try to lift a 5-pound weight. It's impossible until I release it. And we haven't even talked about, you know, the number of people who say the tongue has nothing to do with speech, and the speech therapists who 5 years of speech therapy, which we fix in 5 minutes after surgery sometimes. I was just working on a slide, an 8-year-old who had a speech problem and been going 5 years of speech therapy. Mother never told me that because the tongue wasn't major. I said, you know what? Why don't we try releasing the tongue? We did. Came back 3 weeks later. It was all gone. Perfect speech now. Bedwetting. If you've got a 7 or 8-year-old home and they're bedwetting.
Yes, people ask us this question all the time. Let's talk about bedwetting. Yes. Yes,
Okay.
This is a big one.
Okay. Night fears. These are things which nobody thinks are related to this.
Right.
So if you go to my website, just go there and look at the 30 questions that are there and rate them 0 to 3 for your child. If they're all 2s and 3s, don't walk, run and get that tongue fixed. And don't go to the operating room. Don't use general anesthesia because that can have an effect on the developing brain also. And when ENT says, come back in 3 years, you've missed your breastfeeding experience and everything else. So parents have to do their homework. They have to understand what they're doing and why.
Yeah, I was the bedwetter. Kimmy was the night terrors.
Well, you've got all the symptoms.
Oh yeah,
You must have been fun as a newborn. Your parents must have loved you.
Oh yeah, I was the colicky. I was the colicky baby. Which is so funny. My mom, instead of like a baby book, she had like a baby calendar, you know, 1990. And on her baby calendar, like when I was 4 months old, she literally wrote, colic is supposed to go away. Like,
oh no.
I don't think colic is a real term.
Like that was the 90s, you know, so that's what she had written on my little baby calendar. And then I think a couple months later, colic actually went away. Like she literally wrote it down. And so I was the colicky baby.
I think colic is a term used by medicine when they don't know what's wrong.
Fair. Yeah.
Reasonable. I don't think that's a real, I think it's a fad. It's an expression used for reflux. And the baby is arching their back and in pain. They call it colic. But you know what? I don't think there's anything, colic doesn't exist. The word exists.
Yeah.
I think they're air-induced reflux, swallowing air, full of gas, and in pain.
Yeah.
Call it what you want.
Yeah.
Symptoms of colic are real, but like, is it a thing, or is it aerophagia, or is it body tension, or you know, all that stuff. Oh, speaking of which, Dr. Kotlow, can you talk to us a little bit about cranial nerve dysfunction?
Well, I think when you look at the tongue, 5 cranial nerves affect the tongue. Okay. So your tongue is not just a single muscle with one innervation. It has 4 intrinsic and 4 extrinsic muscles that allow you to move in every direction. It's the only muscle that's only attached at one end, and it's attached through fascia right to your spine. If you do a dissection of the body and keep all the fascia together and you wiggle your toes, your tongue is going to move. So that tongue, because you have 5 cranial nerves innervating it.
And actually, real quick, sorry to interrupt you, just for our listeners who may not know, how many cranial nerves are there? So 5 out of how many?
Now you're getting it. I think there's
They're
I think
12.
there's 12 cranial nerves.
Well,
Yeah. So almost
Yeah.
half. Mhm.
Yeah.
Yeah.
They all come out different spots in your
Mhm.
skull. But so of those, I mean, you have cranial nerves that work your diaphragm, okay, and all different parts of your body. But there's muscles for the tongue. There's muscles for different innervation on there. I don't want to go through them, all of them, but there's 5 different cranial nerves that have innervation in the tongue. So it's a very complex organ. It's not a simple muscle.
Yeah.
and how does body tension in the neck or from utero cause cranial nerve dysfunction? I've heard that from like pediatric PTs that they say it's that the cranial nerve dysfunction from the way that they sit in utero also is a factor with the tongue function in the babies.
Look, if you get a lot of neck pain back here,
Mhm.
okay, that's when your cranial nerves going down there, it's getting compressed. And you go to the chiropractor, body worker, and they work on manipulating things to open up the areas that are it's surrounded by different kind of tissue. And if that fascia is compressing it, it's definitely going to cause pain or discomfort depending on which cranial nerve you use. And there's a whole series of lectures on how the position of the head and neck and your vertebra can cause compression, because some of these nerves come out of the skull, go around the vertebra and stuff. I don't want to get too far into that. It gets kind of complex, but I think when your posture is off, you're compressing nerves, pulling on nerves. It's sort of like lower back pain where you have a disc that gets thrown out. If the nerve is blocked or compressed because of positioning or because of the way the muscles are pulling or fascia, it can cause dysfunction.
Interesting.
And that's a simple
Interesting.
answer.
Yeah.
Yeah. I love it. Oh, I feel like we've covered. This is actually, I just kind of told Kimmy this into the chat. This is one of my favorite episodes. I feel like
Yeah.
we talked
Fascinating.
about like so much like good stuff, like so many like nuggets for us to share. Before we wrap up, I mean, I know that, you hear 10, 12 times a day, mother struggles and then, things really change. Is there any particular like story that sticks out to you as like a big success or, a kid who you really worked with? There's probably too many, but if there's any you can think of off the top of your head, that's your favorite.
I hear the same story every day.
Yeah.
I had one mother come in crying chronically, telling me she's on drugs, she's got postpartum depression, and she can't nurse. She came back a week later, offered drugs, and was happy as can be. I've gotten mothers who come in all the time who've been told it's all their fault, they're not a good mother.
Oh.
I think the fact that I have many mothers who come in crying and stressed, and they walk out happy, make it why I don't retire and why I keep going. And the same for my staff.
Yeah. I just got chills because
I know.
I'm thinking about so Isabel's 17 months, almost 18.
I mean, go back to
about that time and how hard it was, and just like.
I mean, talk about what you've talked about. If I could walk up to you in 3 days after your baby and take my hands and take that off your shoulders and throw it away and everything was perfect, how you feel. So,
oh yeah,
I'm changing people's lives every day. And
hugely.
Unfortunately, we always talk about the breastfeeding dyad, which I used to think was the tongue tie and lip tie. Okay. But in this day and age where everybody's going crazy, you really need to call it a triad. If the baby is crying all the time and the mother's not happy, it changes the whole dynamics of the whole entire family. So if we get a mother who's happy and a baby who's happy, the dad's going to be happy. There's a mystery writer, and I had a laugh because I read his book, and one of the main characters was a police sergeant who was complaining to his friends. I said, we had a baby about 6 weeks ago. I come home, and as soon as I walk in the door, My wife hands me the baby and says, the baby is yours. And I don't get any sleep. That's why I'm having so many different problems. And all the symptoms are talked about. And he's solving a murder mystery. So I wrote him, I said, maybe you ought to think about the mystery that you had with the police officer and his wife. You should have said, go see your physician and get the tongue fixed. Okay. So he wrote me back. He said, well, you can't worry about all the problems of the world. I said, yeah, but you stress so much problems with this guy being sleepy and tired, and you wrote it into your book. You should find out why that's occurring. I have a lot of autistic kids and kids who are ADD and ADHD. And when we release the tongue and they start breathing, they come back a month later, the circles are going under their eyes. And parents have said, you've changed our lives. I think the comment that is universal when we're successful, because I have the parents write me, fill out a form a month afterwards, and they always say, you've changed our lives for the better.
That's amazing.
And I think that there's so many stories that are similar that, and to pick out one particular, I can tell you two more funny ones. I was watching football in December, and I got a text message at 6:00 at night from a woman from Costa Rica who was having all these symptoms. She was an American woman living over there. Mm-hmm. And I said, I'll tell you what, I'm going to Costa Rica next week. This is where I'm staying. Are you close to it? She said, yes. I said, I'll meet you at the hotel and I'll take a look at your baby. And the kid was severely tongue-tied. So 2 weeks later, they flew from Costa Rica to my office.
Oh, wow.
Take a look at it. I've had other mothers with fly from California. They've had 5 surgeries, but they weren't done correctly. I've had others fly from Europe because they couldn't get care. I have a lot of American citizens who are based in Germany or other place who fly back to the States. There are more people doing it today, so I don't see the same number of patients outside. I mean, I had patients, I think, from 49 out of 50 states and 15 different countries.
Wow.
Amazing.
I recently had a patient from northern Michigan, took a taxi cab ride for 10 and a half hours because they couldn't find anybody. And when I gave them names of people closer to them, they said, no, we're coming to see you. We won't see anybody else. So,
yeah, you're not allowed to retire, Dr. Kotlow. The world needs you.
I would say, if you ask me what, in all honesty, what the thing or parent or thing that gives me the most pleasure, it's what my staff and I do to help families. Mm-hmm. That keeps us going because everybody who comes in thanks us profusely when they leave of being there to help them. And that's our goal, to help them. Mm-hmm. Help families.
I feel so tender towards you. Thank you for all of your work, and thank you for sharing your message today, and also encouraging people to be a little braver when it comes to doing releases, because so many people are so chicken about it. I know Megan and I wish we could go to dental school. We just don't want to deal with it.
Yeah, somebody give me a laser.
Yeah.
Doing a release and doing a release correctly are two different
things.
And knowing what you're doing and keeping out of trouble. Mm-hmm. You know, we've done about 40,000 babies over the last 20 years. Whoa. I do about a little over 2,000 plus. And, you know, right now we're seeing anywhere from 10 to 17 surgeries a day of different ages. Wow. A lot of repeats. You know, COVID left people with nothing better to do than make babies. So they're having 2 or 3 babies in 3 years. So they're keeping me very busy, let me tell you.
I love it. Thank you so much for coming on and for sharing your beautiful message and teaching us and making it so simple and straightforward. We really appreciate you, and we
My pleasure.
Love the work that you've done. And if anybody wants to find your book, I will link that in the description, SOS for TOTS. And I will also link your email in the description, as well as your website. Can you say it one more time for our listeners?
Kids Teeth, KIDS DDSTEETH, Kids Dentist, KIDDSTEETH, either at AOL.com for my email or .com for my website. And my website has all the information. If you've not been there, it's just been redone.
Yeah, it's a
It has everything on laser surgery from newborns up to teenagers with gingival problems because of braces. It covers all the aftercare that I recommend doing and how long to do it. It covers the surgery so the parents can see it's quick and easy. It takes about 12 to 15 seconds. It's bloodless for the most part. And the only real complications when done correctly, and that's for emphasis because
when done correctly,
done correctly with the right tools,
yes,
is reasonably safe. And you should be able to handle emergencies. We don't use any drugs. We don't use any chemicals. We use sugar water. We don't numb babies. I know people are out there using local, which is wrong. They're using topical, but that's their policy. Okay. And, I'm not there to teach them what they're doing wrong. I'm seeing what they should do. But if you use a laser, the right laser, and you know what you're doing, babies cry when they're hungry. Babies cry when they're wet. And you know what? They cry when they get a shot from the doctor. They cry when they get a shot from a dentist. But you know what? That the 10 seconds it takes me, I want the baby to cry because a crying baby is breathing. Babies do not run into problems with cardiac problems. They run into problems due to respiratory. So if I'm working on a patient and that baby, one of the functions of my staff is not just to hold the baby, but if that baby is not crying for more than a few seconds, they actually stop me and say, okay, this baby needs to take a few breaths because I'm concentrating on what I'm doing. And their job is to watch the whole baby. It's like, sort of like if you were having open heart surgery, the surgeon is concentrating on what he's doing, but the anesthesiologist is keeping your patient alive. Well, in a good practice, I have two assistants who are controlling babies' movements, not on their mother's lap, but in the surgical position in a Trendelenburg, so the airway is kept open. They're watching the baby breathing and everything. Not that it's not my responsibility, because I'm listening and watching too, but when you have, 6 eyes and 6 hands watching what's going on. I got people doing surgery in mothers' laps without masks, without caps, without gloves. Okay, I know one doctor who says, he does all his surgery in the baby car carrier. A study was done over in London that the car carrier your baby's in has more bacteria than the toilet seat you sit on.
Honestly, I believe that.
Okay. So anyway, we
now
don't
that
want
I've
to go
had a
there
baby,
today.
I believe it.
Let's just to say that it's a safe procedure.
Yeah.
It can be done without general in the hospital. Personally, I prefer lasers, and all lasers are not the same. There are some that are better.
Right.
Skill of the surgeon, knowing where to cut, not to cut, and parents following the aftercare. You're going to get, the responses I get are 95% or better. And keeping in mind that probably up to 50% of the patients' parents never come back to me until the next baby because they're more than 3-4 hours away. So they all get my personal cell phone if they have a problem, and they get printouts, and most of them get copies of my book.
That's awesome.
Anyway, thank you for inviting me.
Thank
I know
you.
we talked a while here.
Yeah, that's okay. We didn't even want to cut it off. We're like, let's keep going. This is awesome.
Okay, well, you can cut it in half and do whatever you want.
It was wonderful.
Yes, thank you so much. Of course, so we told you guys how you can find Dr. Kotlow. You guys know, hopefully by now you know how you can find Kimmy and I, but if not, you can follow us at the Munch Bunch Podcast on Instagram, Munch Bunch Mayo Podcast on Spotify or on YouTube. You can find myself at NWFT, Northwest Myofunctional Therapy. You can find Kimmy at Mouth Muscle Memory. We are here if you ever need us, have questions, And we're excited to keep bringing on guests like Dr. Kotlow. So thank you again so much for your time, for your expertise, for pioneering the field. So Kimmy and I have careers.
Well, I appreciate having you there to help the mothers as well as I do.
Yeah.
And I would encourage both of you to go to my website and look at the new instruments.
Yeah.
Because it'll make your aftercare, before care, and assessment much easier to use.
Yeah, that'll be awesome.
Okay.
We're definitely going to deep dive. We're instrument nerds, so you know our you know our background's dental hygiene, so we're instrument nerds, so we're into it.
All right. Well, thank you for tonight.
Yes,
I appreciate it.
Thank you. All right.
And if you need me again, anytime.
Awesome.
Thank you.
Thanks so much.
Okay. Bye-bye. Good night.